So the idea of this session is every third year when we have IPEG and SAGES as a joint meeting, we try to have a couple of joint sessions like this. And this particular one, there are a lot of cases, a lot of procedures that we do that are quite similar. They may be for different diseases or different indications, but a lot of the procedures are similar. And it's funny because we go off in different directions and we don't talk to each other very much, and we find that someone in one specialty does it quite different. So the point today is to go over 3 very common techniques, 4 actually, and we're going to have a pediatric surgeon present their way and the adult surgeon present their way, and if we have time for discussion, we will go into that. So each speaker has about 10 minutes to present, and we'll go from there. Just to start, if we can pull up the talk, my talk, it's, let's see, is it 119? There it is. I'm just going to teach everyone here why this poor old guy does the wrong technique. It's very sad, but it's okay. You know, he has to learn when it's time to switch to the right technique. So let's talk about gastrostomy, the old way versus the right way. Circa the time of the development of the light bulb and the Model T Ford, Dr. PONSKY and Gowderer worked on the development of a percutaneous endoscopic gastrostomy in 1879. Oh yeah, I'm sorry, it's 1979. It just seems like so long ago, I just can never keep the date straight. You know, I have to say, these guys were geniuses. They really were. What they did before laparoscopy was really mainstream was amazing, considering the very primitive material that they had to work with so long ago. I mean, this was the only way. They said, we don't want to do a big incision for a gastrostomy. Let's use something, an endoscope. That's really all we have. Let's do a technique, and it's a really genius idea. You pass an endoscope down into the stomach, you blindly jam a needle into the abdomen, you hope it goes into the stomach and not through all the other organs, and it's a genius idea. That's how you do a PEG. And you know, the problem is this technique still the right way to do it, now that we have other tools like laparoscopy? Well, here are my concerns with PEG. First of all, risk of colon injury. I get that most of the time it's going to work well, but without seeing inside the abdomen, there's a chance they can go into the colon. Here they always show the picture of a PEG like this with the colon way down far, but the truth is, the colon oftentimes is like this. And I know he's going to tell you about all these cool tricks and techniques you can do to make sure you don't get a colon injury, but the truth is it happens, and I'm not willing to accept that. This is what can happen. You cannot control where the PEG is positioned, and for pediatric surgeons this is important, considering a lot of our patients end up going on to having a Nissen in the future, and we want to be able to position the G-tube exactly where we want it, whereas Keith Jorgensen was saying yesterday he's never once had to reposition a G-tube after it's been placed laparoscopically when he's going on to do a subsequent Nissen. A long G-tube can be pulled out by the patient. We like to have buttons so that they don't have to pull out, especially if they're neurologically impaired, they can pull it out. Early tube dislodgement requires surgery. You put in a PEG, there's nothing keeping the stomach up for the first couple of weeks. So the tube comes out, the stomach falls down. So in the technique I'm going to show, we do it by stitching the stomach up. It's a better chance of reaccessing the G-tube. Tube removal is painful. Now, especially in kids, just ripping out this thing, hoping that that mushroom doesn't hurt on the way out, it's painful. So G-tube, you put a button, you put the balloon down, and it's pretty easy. Now, you know, Pops, you know, when you were spending too much time riding your horses, you weren't paying attention to something that really is spectacular. We developed something called the laparoscope. I know you've probably never seen one before, but let me explain to you what it is. You actually can connect this to a screen and look inside the abdomen. It's a novel new technology. It's something that really would have helped place a G-tube. I mean, think about it. When you described PEG, this was the idea. You make an incision in the left upper quadrant, and you put a needle through. Why not, through that same incision, put an operative scope through there? It's the same one incision. This is what I do. This is a 4mm operative scope. We make the incision, the same incision you would make for a PEG, but instead of pricking a needle in, you put an operative scope in, you grab the stomach exactly where you want it, You pull it up through the abdominal wall. Granted, you can only do this in small children. And then you fasten it with a purse string and then fascial gastric stitches, and then you can put the button inside. It takes usually about no more than 10 minutes, 7 to 10 minutes. They do require anesthesia, and we can talk about that. This is how I check to make sure it's in, by getting betadine through. But really, the technique that probably the majority of the people in this audience use is that described by Dr. Jorgensen. This is his technique, shortened to a very short amount of time, so Keith, I apologize. But the idea is putting stitches in the stomach, laparoscopically. You fasten the stomach up to the abdominal wall, and then percutaneously, under visualization, you can watch the tube go in. Who uses this technique? Majority of the audience. I'm so happy this is in the IPEG room and not the SAGES room. Here's the arguments he's going to make. It does not require a general anesthesia. Well, I'm not so sure general anesthesia is a local or a sedation is safer than a general anesthesia. I'm not sure that that's necessarily better. But all procedures we do require general anesthesia in children that involve the abdomen. Less invasive, I don't think so. If I make one incision in the left upper quadrant, I don't have to make 2 passes with an endoscope. And perhaps, I will say, in fairness, probably the most compelling argument of why PEG should win this argument was given by Michael Rosen in an email that he sent to both of us when he found out we were debating this. He said, clearly a PEG is better. It paid for Todd's education. There's no need to argue any further. Good point. Good point. Now, before we trust him, I just want to show you, this is other technology that Jeffrey Ponsky swears by. So before trusting him, you might want to take note of this. He's a great mentor. He's taught me everything I know, but before you trust him, you gotta really think twice. Do you trust this guy? All right, your turn.
Well, son, put up the real slides. What I have to say to you, is that all you got? Bring it on. And we have the regular slides, or is IPEG going to hold those back? PEG versus laparoscopic gastroscopy. Are you kidding me? Are you really kidding me? In the beginning, gastroscopy was done by laparotomy, and these are some drawings of how a stam gastrostomy is done. And interestingly, the stam gastrostomy doesn't look a lot different from what you just showed. This was Todd about 1980, back when we were starting to do PEG. And as we moved on, Michael Gowder, who is very important to remember. Michael is a very active pediatric surgeon. He's in South Carolina, and he's a brilliant and innovative man, and really came up with the concept of PEG, and we innovated it together and described it. And this was one of our first patients, which I think qualifies as a pediatric surgery patient. And when we did that, we noticed that, as Todd, there was no question where the stomach was. It was quite clear where the stomach was, and if you couldn't hit that, maybe you do belong in pediatric surgery. But anyhow, we could puncture the stomach quite easily and actually catch a string and drag it out through the mouth and drag a tube back down, follow it down, and here it was going into the abdomen. This was about 7 minutes later, and it is sutured to the abdomen in a child because sometimes they can't pull it out. But this is what it is. Now, what about this technique? In a baby, it does require general anesthesia, but it does not require laparotomy. And you know, it was simple, safe, and effective. And since it was introduced, there's been about 5 million of them done. About 5 million. How many is your series got? All you together times 5. There's been about 5 million PEGs done. Now it's improved. This was another child that we did, and we showed in this one that you could do it when there was previous abdominal surgery. Well, you can do laparoscopy when there's previous abdominal surgery, sometimes. But sometimes that laparoscopy, when there's been previous abdominal surgery, implies an increased risk, and I think I'll show you that. We do it for other reasons, for oral cancers, for gastric distension and for decompression, for biliogastric fistulas, for reduction of volvulus. Oh, this is one of my recent patients. I want you to show me your technique in this guy, Todd. 5 minutes later. This was double PEG for reduction of a paraesophageal hernia in a patient who had terrible, terrible cardiac disease. And we reduced it in this patient. We were able to choose 2 different places to put it quite selectively. This is a man who had metastatic cancer with a frozen abdomen and carcinomatosis. We were able to put a decompressive PEG in between his lower 2 ribs over here, because we saw the indentation in the light. Laparoscopy in this guy, not easy. Not easy. So PEG does help. Now, when Todd was growing up, I paid for this monkey he's holding. And he grew up and he was a fighter. This isn't the first fight I've had with Todd. I paid for his vacations, and eventually he became a very renowned pediatric surgeon. And now he's talking to you about laparoscopic gastrostomy, and he's very, very excited about single port surgery. I just think he needs to continue his education, so that now you want to do laparoscopic gastrostomy, but the problem in this room is that pediatric surgeons are really uncomfortable with flexible endoscopy, guys. You're uncomfortable with it, and you're comfortable with laparoscopy, and you need to learn both. And I think that Todd needs to stick to his knitting and continue to learn, because PEG is the better technique. Thank you.